A point in the life of PhD candidate Deborah Coffee. Allen. I asked her earlier what was her real name. And of course, I should have written it down because I've got a very short memory. But we want to welcome you this afternoon to her oral defense. I'm talking a little bit slowly because we're waiting for the last committee member. But in the meantime, Deborah has worked very hard in putting together her document. She has been committed to the program and committed to research. So we know that as she moves along in her career, that she will do well in research. She has already proven to be a very skillful clinician and educator, and now she's moving on to research. So we expect great things from her. So I would like to welcome you to her defense this afternoon. And the way that we usually do this is, once I finish with the introductions of the committee, I will say a few words about Ms. Allen. Then she will introduce herself, those few things she'd like to tell you about herself, and then she will go on with the presentation. Once the presentation has been completed, then once again I will ask committee members to direct their questions to her. Once they have completed their list of questions, then we will open it up to the audience, so you will have a chance to make comments or ask questions about her research process. Okay, so sit back and relax. And if you would, please turn off all cell phones, because we don't want to distract our candidate too much, because she might forget to tell us something that is super important. At this time, I would like to introduce the Dissertation Committee and Dr. Whitney, who is the Dean of the Graduate College. For the graduate program, for myself as the Assistant Dean for Academic Affairs, I have two bosses. I have Dr. Whitney, because I have the graduate department, and I have Dr. Hendricks, who is actually the Dean of the School of Nursing. Dr. Hendricks. We also have some other illustrious faculty members in our midst, and one I will mention is Dr. Bertha Davis, who works very diligently with research in our department. Dr. Davis. Okay, now as far as the committee, Dr. Jane Servonsky is one of our committee members. Dr. Zina McGeen should be on her way. Dr. Zina McGeen is in the Department of Sociology, and she has been working with Ms. Allen also. And I am Dr. Arlene J. Montgomery. I'm the chair of the Dissertation Committee. So at this point, Ms. Allen, would you like to share a few things and then go on with your presentation?
Okay. My name is Debbie Allen, and I received my bachelor's degree from Liberty University and my master's degree from Old Dominion University. My background is in pediatrics, is what I did in the hospital setting, and I'm also a nurse practitioner, and I work in pediatrics and internal medicine for the last few years, and that is how I came up with the topic of coping patterns of parents with chronically ill children. So it has been an interest of mine for quite a while, and it has been a struggle for parents who have these type of children to figure out where to go. Okay? So with that, I would like to just begin my presentation. I'm getting feedback, are y'all? Okay. Okay, so let's begin. All right. Well, before I begin, I would like to say thank you to the committee, Dr. Hendricks, Dr. Davis, and also for my family for being here. I have my mother. hard. My father, he couldn't be here today.
But we're videotaping for him, so you'll have him.
My two sisters, my husband, and my son. Okay, all right. It is estimated that more than 133 million Americans have a chronic condition. Many of them have more than one. It is also estimated that this number will increase by more than 1% by the year 2030, and that will be approximately 46 million people. It's also estimated that approximately 15 to 18% of all children in the United States have at least one chronic condition, that limit their activities and require hospitalizations and/or home care visits. Many children suffer from more than one of those. Okay? And the Healthy People 2010 goal is to increase the proportion of states that have services for children with chronic conditions or disabling conditions. Another one of their goals is to reduce the number of people with disabilities in institutions. Judson, an author of an article in 2004, maintains that a child with a chronic illness will experience one or more of the following problems: a limitation of a function appropriate for their age and development, a disfigurement, a dependency on medication, a need for more medical care or related services than usual for the child's age, and special ongoing treatments at home or in school. People are living longer and are expecting a better quality of life than in the past. Technology and medicine have improved, but unfortunately delivery and access to care has not. Okay? And these people with these chronic conditions are requiring more health care than people without. And so health care expenditures for these people are increasing. Problem statement. The illness trajectory is more unpredictable and the impact on the family is more intense when a child is ill with a chronic condition than it is with an adult. When a child is ill, the entire family is affected, especially the mother, who assumes the majority of the care for a child. Okay, a chronic health condition and its management is influenced by the growth and development of the child, as well as the ability of the family to function as a whole. Okay. Parents must make adjustments such as changes in their schedules, which include coordinating school activities, doctor's appointments, medication regimens, job responsibilities, and the normal activities of daily living. These things are tested even more when parents have to get up in the middle of the night to care for their children, because this increases their stress, as many of them still have to work. Many of them are going back to school, and they can't do all these activities and still take care of their children. Okay. Statement of purposes. The first one was to investigate the parental coping experiences of parents with chronically ill children. The next one was to examine the relationships between spirituality and depression in regards to parental coping and demographic factors such as age, gender, education level, ethnicity, and family income. The next one was to increase the understanding of parental coping experiences in an effort to facilitate the best ways to assist families in recognizing their current effective coping strategies and to help them employ new support and coping strategies. Okay, and the last one was to add to the body of nursing knowledge regarding the support systems used by parents, depression among parents, and if spirituality is an important coping mechanism. The conceptual framework chosen for this study was Betty Newman's systems model of nursing, which views the client system as a dynamic system of interrelated variables that are constantly interacting with stressors from the internal and external environment. The Betty-Newman model has 3 concentric rings. The outer layer is the flexible line of defense. In this particular study, this is with the parents' coping strategies. The next line of defense is the normal line of defense. This is the parents' coping patterns. And then you have the lines of resistance. All this is used to protect the core, which is the client. And any break in any of these lines is what leads to a decrease in wellness. So what we try to do is help these parents to recognize when stressors are coming, help them see where their coping patterns are and help them to deal with that so that they can stay in a well-balanced state. Okay? So within each system, there are 5 interacting variables. Ideally, the 5 variables function amicably and are stable in relation to the stressors of the external and internal environment. Those 5 variables are the physiological, the sociocultural, the psychological, the developmental, and the spiritual. In this particular study, the physiological was represented by the chronic illness of the child, and that was measured by the coping health inventory for parents, or the CHIP scale. The sociocultural was the seeking emotional support of the parents, where they go out and try to seek support from their friends, relatives, community support systems. And that was measured by the Family Crisis Oriented Personal Evaluation Scale, or FCOPS. It's a lot for me to say. The next one was the psychological, and that was the perceived stress of the parents. And that was possibility of depression. And that was measured by the Beck Depression Inventory Scale, or the BDI-2. And then the developmental is the achievement milestone, which we didn't look at because we were looking at the parents' coping. And then the last one is the spiritual, which is looking at spirituality and coping, which was measured by the Functional Assessment of Chronic Illness Therapy Spiritual Well-Being Scale, or the FACET SP12. All right? Now, there were 9 research questions in this study. The first one looks at what support systems are used most often by parents of chronically ill children. The second one were what coping strategies are successful in helping parents of chronically ill children to adapt. The third one, what is the self-reported measure of severity of depression among selected parents of chronically ill children? The fourth one is what is the use of spirituality as a support system among parents of chronically ill children? The fifth one is there a relationship between parental coping and spirituality? The sixth one is there a relationship between parental coping and depression in parents who have a child with a chronic illness? The seventh, is there a relationship between parental ethnicity, education, age, gender, income, and coping of selected parents of chronically ill children? Number 8, does the relationship between coping and spirituality differ by parental ethnicity, education, age, gender, and income? And the final one is number 9, does the relationship between coping and severity of depression differ by parental ethnicity, education, age, gender, and income? The research design that was used was an exploratory descriptive correlational research design, and the analysis was completed using surveys by the parents. Okay, the parent sample characteristics. It was a convenient sample where 205 parents were recruited, parents who had chronically ill children. The children were diagnosed between 2 and 5 years from 4 local physicians' offices. Had requested 14 physicians' offices to participate, but only 4 were willing to participate in the study. The age of the parent sample ranged from 18 years to more than 60 years, and that was how the demographic data sheet was clustered. The sample consisted of 187 mothers, which was approximately 91%. 82% of the respondents were African Americans. 48% of those parents had at least some college, and approximately 40% of them had an income greater than $32,000 a year, and 23% of those had an income of less than $10,000 a year, which is, we know, below the poverty line. Of the child sample characteristics, the children's ages range from 2 to 21, with 70 of them in the age range of 7 to 11 years, which was the highest number. The sample consisted primarily of male children, 115, and the illness reported most frequently was asthma, but other illnesses reported were developmental delays, ADHD, heart disease, neurological disorders, oppositional defiant disorder, and I think that's getting seen more and more today. Okay, procedure. Number 1 had to be approved from the Internal Review Board here at Hampton University, and then permission was given by the physician owner of the 4 facilities that were used here in Hampton and Newport News. Then I met with the office manager of each facility and trained them regarding the study, the data collection techniques, and if there were any concerns from each parent, they were allowed to get in touch with me by telephone, or I would go to the site. And then packets were distributed to each site for completion. And then the parents were approached after checking in with their child for his or her appointment at the office by either the researcher or the office manager for voluntary participation. The instruments that we used in the study were the Coping Health Inventory for Parents, or like I said, CHIP, the Family Crisis Oriented Personal Evaluation Scale, or FCO, the Functional Assessment of Chronic Illness Therapy, Spiritual Well-Being, FACET SP12, and Beck Depression Scale. And they all had a coefficient alpha greater than 0.70, which is reliable, according to Lobiondo, Wood, and Haber. Data analysis, I used descriptive statistics and frequencies, bivariate correlational statistics, and regression analysis. I'm going to get down to what was actually came out of it. The research question number 1, what support systems were used most often by parents of the chronically ill children? The 3 most common ones were believing in God, which was 85.9%, talking with a doctor about the child's medical condition, which was 81.5%, and making sure the prescribed treatments were carried out at home, which was approximately 80% of the time. Research question number 2, what coping strategies are successful in helping parents of chronically ill children to adapt? The 3 most common ones were doing things with my children, which was 85.9%, believing that my child has the best medical care possible, was 84.4%, and having faith in God, which was 82.4%. For research question number 3, what is a self-reported measure of the severity of depression among selected parents of chronically ill children? Even though some of the articles said that there was a lot of depression among chronically ill children, overall depression didn't seem to be an important factor to these parents. I had 160 of the parents who showed minimal or no depression at all. 205. What is the use of spirituality as a support system among parents of chronically ill children? The most frequently used spirituality strategies reported were the reason for living, which was 90%. I find strength in my faith or spiritual beliefs, which was 71%. And I feel a sense of purpose in my life, which was 69%. Question number 5 is there a relationship between parental coping and spirituality? The Pearson product correlation was 0.331, which is for p-value greater than 0.01. And that was the correlation between the F-copes and the FACIT SP12. Question number 6, is there a relationship between parental coping and depression in parents who have a child with chronic illness? Again, there was no significant correlation between parental coping and depression. This was between the F-copes and the Beck Depression Scale, and that was a negative 0.124. For question number 7, is there a relationship between parental ethnicity, education, age, gender, income, and coping of parents of chronically ill children? This was looking at the demographic sheet and the F-copes. There's a negative correlation between parental ethnicity and seeking community support. So that just meant that the parents weren't going out there looking for the community resources that were available to them. They weren't going out there trying to get help from their neighbors. They weren't going out there trying to get help from their families and friends. Okay? There was a negative correlation between parental education and seeking family support. So the higher a person's education level, the less they were going out there trying to get help from their family. There was a significant correlation between both the variables of parental education and family income and the coping strategies of waiting long enough, the problem will go away, and feeling that no matter what we do, we'll have difficulty handling our problems. These parents just felt that they were trying to avoid the issue, and that they were just knowing that there was always going to be a problem. Research question number 7 continued. There was a significant correlation between the parent's age and seeking professional help, participating in church activities, attending church, and seeking advice from the doctor. So as they aged, they seemed to feel that they could seek professional counseling, go to church more, get advice from their minister, and they were more willing to ask their physician for medical advice. And for the instruments that I used, there was no correlation between gender and any coping strategy in the outcome. Does the relationship between coping and spirituality differ by parental ethnicity, education, age, gender, and income? This was with linear regression at a 0.05 significance. Ethnicity and gender are positive predictors of the use of coping strategies and the use of spirituality in parents with chronically ill children. And age was only a slightly positive predictor in these parents. Does the relationship between coping and severity of depression differ by parental ethnicity, education, age, gender, and income? Ethnicity and gender were positive predictors for depression and the use of coping strategies in these parents. Again, this was with linear regression. So only, I told you I had a few that did have some mild depression. So as they, it was just only the ethnicity and gender, but I did have that large population of African Americans, and they were female. Okay. So in conclusion, there were 6 top coping experiences identified, and I'm going to go from the highest to lowest. Doing things with my children at 85.9 and believing in God, we're both 85.9. Believing that my child is getting the best medical care possible at 84.4. Having faith in God at 82.4. Talking with my doctor about my concerns about my child's medical condition at 81.5. And making sure that the prescribed medical treatments for my child is carried out at home at 80%. Spirituality continues to be the predominant coping mechanism revealed. And contrary to what may be a common belief, depression was not found to be prevalent in the population. Some of the limitations of the study, to generalizability of the study. Chronically ill children often visit physicians, specialists instead of their primary care. Parents could have more than one child with a chronic illness. Children with one chronic illness have comorbid conditions. And then self-reported by the parents. They may tell you what they want you to hear and not what's in actuality. So the implications for nursing is that we need to develop patient education so we can look at what is specific to each family and look at their coping patterns. And that way we can help them to cope with what's going on in their particular families. And then we can help them to seek community resources that are available to them, help them recognize what's out there, and then they can use them for what's going on. Health promotion strategies. Nurses can relate the Newman system model to the levels of prevention. Because now they already have the disease, so we're not looking at primary, but we can look at secondary and tertiary to help them go back so that they're not getting any deeper into that, and then reconstitution can begin. And then if we are in education, like I am, planning course materials to help new nurses learn about chronic illness and how to help people and parents with a chronically ill child. Okay. For future research, more research needs to be done looking at siblings of chronically ill children. There's not much out there looking at how it affects the siblings. We need to do more on fathers of children with chronic illness. Again, like I said, a large part of this was looking at the mothers because they do the majority of care. And this may be that fathers are responsible for taking care of the bills, making sure that they get paid, and so the mothers take it to the offices. And so we may need to look at going out and finding out what fathers are. Child's coping patterns compared to the parents. They have different coping strategies. The use of religious coping by children. Children learn as they are going through their development, and they look at how their parents cope. And as their parents are coping with their issues, at some point when they reach adolescence, they start questioning their religion, and so their answers may be different. And then replicating studies, looking at the comorbid conditions, looking at a larger sample size and geographical area, looking at severity and length of illness, and then triangulation, doing a mixed method. And then, any questions? That's a good question. spirituality and religion. Okay? Spirituality is having a purpose, okay, and having a meaning. Okay? And having a reason for living is getting up and going to work every day, doing your everyday activities. Okay? And finding, having a purpose is a goal, a direction, that you're actually going somewhere. Does that answer your question?
So it's more than going to work.
Right. It's just you have a reason for being here. You were put on this earth for a reason. Whereas the purpose is that you have a direction, a goal. Okay, next question?
Just to add to that, when she's looking at spirituality, she's looking for at the meaning of life, whereas religion is a part, but it's kind of a subscript to spirituality.
Religion is the formal part of spirituality. It's what you do to show spirituality, whereas spirituality is a broader term.
Question 7, research question I had a question here. You said you had a negative correlation between parental ethnicity and seeking community support.
Correct.
What does that mean?
That means that these parents were, because I had such a large population of African Americans, had I had a larger population of Asians, Caucasians, I don't think it would have been so, it would not have looked that way, but it was showing that this large population of African Americans were not using the resources of the community that were available. So they were not using the groups, like community resources that were there.
I think I'm sort of missing something. It's stated on the slide, which it's stated between parental ethnicity and seeking support. The negative correlation, I thought that sort of like a negative slope. Was like increase one eye and then goes down.
Right.
Right? So, how do you increase that? No, I'm just curious. I don't quite understand the interpretation. Maybe there's something there. I just want to see. You got a negative correlation coefficient.
Correct.
Right? So that's why you say it's a negative correlation.
Mm-hmm.
Right? So ethnicity then was scored in terms of American score, one ethnicity being 1, another being 2, another being 3.
Correct.
Okay. And so African American was on the higher end, and the negative correlation, they saw less community support.
Correct.
Okay. I understand what you're saying.
Okay. Next question.
I don't have any questions for you today about your study. You must be glad. But I wanted to know where do you go from here as far as your program research?
Well, I would like to continue this one and look at more of the coping and looking at a larger population. And I would like to do a mixed method because I think that would open up some of the ways that parents feel, because some of the parents did write comments in there, and I think that would open it up. Okay?
So a couple of general ones. The first one you've already answered, because I was going to ask you, how do you think this study would have differed if you had used a qualitative method? And of course, you just answered part of that about responses to Dr. Servonsky's question. What did you find was the most difficult part of conducting this study?
finding the population and being open to doing it. And like I said, I contacted the 14 offices. That was a large part of it. And then getting in there, because that was difficult.
How will you use this data in your practice as an educator?
As an FNP, I will use it to help parents, number one, to seek some of those community resources. I've already started looking at some of the resources that are available. I was not aware some of the community service board resources that are available. When I started this, and I said the community service board would be available to my population, I actually had to call them and say, what do you have available? And talk to them and find out what is available to them. And I also talked to one of the physicians that I work with who was there, and using that. And then as an educator, I would like to educate my students as far as, since I teach an FNP program in the pediatric course, incorporate that.
And keeping in mind that we had two folks trying to find out what resources were available that may possibly have some impact on why your sample of those parents were not using resources because they didn't know that they were.
I had one more question. Was a person's church, did that count as a community resource?
Yes.
It did.
Yes.
Now, are there questions from the audience? Ms. Figueroa, yes.
When looking at question number 3, were you a little surprised at the result of that question? And if not, do you think that the correlation of spirituality and coping is what may have the results of this question, may have added to the results of this question, or do you think it's the underreporting, or maybe there was a possibility of underreporting of parental as far as the depression is concerned?
I was surprised because of the literature that talked about the depression in parents with chronic illness. And when I actually did the research and found that this particular population did not report it, I was surprised. But I do think, and that was part of the limitations, that the self-reporting of the parents, I think they give you what they want you, what they think you want. And then I think that they don't always want you to know their business. And the 4 physicians' offices that I work with, they all know, the families know each other. And I think that they did not want their family members to know or to have any part of their business being known. So I'm not sure that they may have accurately reported. That answer your question?
Yes, Dr. Whitney.
Could the answer be different if you guess limited cases where the chronic illness was only like 6 months old instead of being 2 to 5 years? So I think when you said 2 to 5 years, when you look at the period, so the parents would be issued for at least 2 years. If you've gone for a shorter time period, you think that is fine.
Yes, I do. And I think that we had, and that's why I said that's one of the limitations. If we had added severity of illness and length of illness, we may have had a different response.
Dr. Harrison.
I have just one question. I want to know what was the most surprising thing you found out. And I want to know what we would do differently the next time you conduct a research study.
I think the most surprising thing that I found was that there was no depression. And the second part of that would be to do the qualitative piece. Because if they could write it I do think that I would get a different response because you can see it. Instead of them just circling, because the Beck depression is a Likert scale, and they had just to choose responses. Correct. And in some of the responses, they wrote in things, and I could not count that. You know, they would circle something and then would write something, but I could not put in a response. Next question.
Was any of your sample population dealing with terminal illness as well as chronicity, or were they all disclosed? What illness was in your sample population?
I only had one that had leukemia, and that was acute lymphocytic leukemia, and that was in my other category. And so that one had not determined whether it was going to be a death outcome. But we were still in a chronicity phase of that illness.
Ms. Brooks and Dr. Hendricks.
I just got a question, because when you look at asthma and other types of illnesses that's chronic, if it runs in their family, other family members have it, and it's like my cousin, the rest of my family, when we got family members in my family that can support me, and I may not go outside. Was that one of the questions to ask? Was it part of their family history, like chronic illness?
Well, that was part of the support system. They went to their families, friends, community. So there were questions related to relatives. Did you ask your family? Did you go to your parents? That kind of thing. So that's part of the support.
But they still didn't change the results that you found.
Correct. That didn't change the results of this.
Ms. Allen, first let me congratulate you on a wonderful study. I am intrigued, of course, by the spirituality findings and am delighted that it continues in many of the research studies to just be the top thing. We keep continuing to document that through scientific method. You mentioned the three top spirituality most frequent strategies used. And then somewhere else over here you talk about 6. Would you be able to share the others? Can you sort of remember? I'm just interested, and that may be a little bit more particular than you want right now. But the reason I bring that to your awareness is that as you look at future research endeavors, because spirituality is a focus in society today. Certainly, that's something you may want to look at and flush out much more. You don't have to even replicate the study. You have the data here, and you have wonderful data. And certainly to look at all of the components of the spirituality instrument and those items that they use will certainly yield scholarship opportunities for you as you publish the many manuscripts we know that will come from this study. Great job, great job.
Dr. Davis.
What is your definition of family?
Family, in this particular study, the family consisted of the parent and the child. And I know that there are a lot of different definitions out there, but for this particular study, it was the parent and the child.
And that's consistent with your conceptual model.
That's correct.
Yes.
I just have a question about your comment about future research looking at fathers, knowing that there are a lot of single-parent families, do you have any, or can you recall from your demographics, were many of your participants from, as in a single family or single parent family, or were there two parents available? I'm just wondering how you might access fathers because they may not be available.
My demographic sheet did not look at single family versus married, but the CHIP did question whether you asked your spouse about things or not, and so that would be one of the support systems that were used.
I knew you looked a long time for this year. How did you decide to use
FCOPS was developed by McCubbin and Hamilton back in 1987 regarding parental coping strategies, and it's been around a long time. It's been used by at least 10 authors out there in different studies, and had very good reliability and validity, and that's why it's used. And that's what I wanted to say. I talked to Dr. Hamilton in Hawaii, which is still my time with all this stuff.
And I asked that question because I asked each person defendant if they have talked to someone about any aspect of their study. And that gives you that secondary support of what you're doing. And this is a teaching point for the people that are listening. That gives national and international support of the ideas that you are bringing forth to study, and how you gather the data about those individuals that are out there based on your problem statement and your topic, so that you have another piece that you can validate with the questionnaire, in this case, the questionnaire you use. And I hope that's written in your narrative, the date you communicated with that person and exactly what it was you communicated with them about.
Dr. Williamson.
I'm just seeking clarification for myself, and I know you started out with 14 offices that you had identified, and you wound up with 4. And just for my own education, was the 4, and I know you could use a physician, were they private physicians, or were you using agencies, physicians that work for state and federal?
I contacted the physicians' offices and pediatricians' offices in Newport News in Hampton. I tried to contact Pitch, and Newport News in Hampton, and one of the CHKD offices that are on the side of the water, and they wanted to participate.
The only reason I was, like I said, because your sample size wound up to select a large African American population, and I just got an interpretation probably you had used some state or federal, but you're saying they were all private.
They were all private.
Do you mind if I ask a question?
No, you're right again, sister.
It's tough on
Sorry,
you.
so that's a simple question, because sometimes we meet obstacles in obtaining our information when we're trying to do research. What were some of the top obstacles that you were reaching in trying to get information from other physicians' offices? When you contact 16 and you only get a response from 4, that's only 25% that's really wanting to be involved.
Well, I did talk, out of the 14, I did talk to all of them.
Right.
But a couple of them were, they were listed as pediatrician offices, but a few of them only did like allergy, one who had allergies. A few of them said, no, I'm not interested, I just don't want to deal with that. We have too much going on in our office. One of them said, well, I don't want to, my office is just not set up to deal with that kind of collection of data. And then, they just gave me those kind of answers. And then there was one lady I just never heard from. And then I went by a couple of physicians' offices and dropped off a packet introducing myself, because I didn't ever get any response back, with my instruments and saying, this is what I'm doing, would you be back with me? And then I would get a response back from the office manager saying, we're not interested.
One last question?
I just had a question. You mentioned a concern about parents underreporting factors like depression, and I'm assuming that you had told them their responses would be kept confidential on the questionnaire, so I was just wondering, why they were still concerned that the information would be released to other people.
Like I said, I just think that because I did use some of the office managers in the office, and the packets were given out in a big manila envelope, and they could seal it when they were done. Even though they were handing it back, I just think that some of them thought somebody might know their business. Because some of these offices, they just all know everybody. And it has their mother comes in, and their sister may come in and bring their child, and, mouths get to talking, and
So much for HIPAA.
Dr. Conlon has a question.
Oh, I said one last. Now this is the next one. Dr. Conlon.
Looking at the depression and spirituality, I was not all that surprised at your finding, because people who have a strong spiritual life tend not to be depressed. I think the literature tends to support some of that. And then the second thing was, so that would be one possible explanation, that going back to the literature, you might find that this is true for and it may be very selected populations it's true for, I'm not sure. Then the other thing was that trying to explain why people were not depressed, and it may be that people who've had experience with adversity have become very strong, and so that this is another explanation, the resilience of the person. And, and particularly with the group that wound up in your study, that adversity may not be is not a new phenomenon, and so that the resilience of this group might explain why you're not seeing as much of the depression. So it's just something to consider. It's like framing the results in resilience theory or something might give you another little clue as to what's a rival explanation for this. And I know that you were not that was not your theoretical framework, so you would have no reason to have done that. But as it goes on and we look at the results, you were surprised. I wasn't that surprised. So it is kind of interesting that would happen. So, but I think it was a beautiful study, and I know that people in those situations will benefit from what it is that you recommend for practice and protocols from your study. I'm very, very glad you did this study.
And it's a comment, it's not a question, next. In your narrative, I hope that you have, get back to the question Dr. Newman asked. When you explain for instance, the relationship between parental and disability, education, age, and income, and coping, also like the parent, that you explain what you found for each variable in your answer. And then, because I'm sure you had like ethnicity, age, coping. So whatever you got for those variables, be sure you explain those things in the mail.
Okay, I won't ask if there are any more questions because there aren't any. Let's give Ms. Arlene. What we will do at this point, the committee will retire for deliberation, and Ms. Allen's colleagues will help her unveil her refreshments. So if you would just mingle, we'll come back and get Ms. Allen.
I got it. Excuse me.
Ladies and gentlemen, may I present to you Dr. Deborah.
Congratulations, we are so proud of you. We are so proud of you. Get to your mom. Wait a minute.
Congratulations, Dr. my student. Dr.